Hey everyone, and welcome. Get ready for a high-speed explainer on all things wrist pathology. We're going to cut right through the noise and give you exactly what you need for some seriously rapid recall.
All right, let's dive right in with a question you are almost guaranteed to see on an exam. You see a distal radius fracture. Is it a Colles, a Smith, or a Barton? Can you tell them apart in a split second? Stick with me because by the end of this, you're going to nail it every single time.
So here they are, the big three, side by side. Let's get straight to it. The number one difference between a Colles and a Smith fracture is the direction of angulation. It's that simple. For a Colles fracture, you have dorsal angulation. Think of the broken piece being pushed toward the back of the hand. That's what gives it that classic dinner fork look. A Smith fracture, it's literally the opposite, volar angulation, with the fragment pushed towards the palm. Now, the Barton fracture, that's a whole different animal because it's intra-articular. It actually goes into the joint space. It's a piece of the radial rim that's broken off. And keep in mind, about half the time a Colles fracture comes with an ulnar styloid fracture too.
Okay, this is one of those clinical pearls you just can't afford to miss. We all know a Colles fracture is linked to osteoporosis, especially in older women. But check this out. If you see this exact fracture in an older man, that should be a huge red flag. Your immediate next step, you've got to order a DEXA scan to check for underlying osteoporosis.
So you've reduced the fracture. How do you actually know it's in a good position on the X-ray? Well, you need a perfect, true lateral view. And here's the landmark you're looking for. Find the palmar or front cortex of the pisiform bone. It needs to be sitting perfectly centered right between the scaphoid and the capitate. That's your green light for a good reduction.
All right, we've covered the distal radius pretty well. Let's move on and look at some more specialized, but definitely just as testable fractures that involve the thumb and the radial styloid.
Okay, two fractures, both at the base of the thumb's metacarpal. How do you tell them apart? It's actually incredibly simple. A Bennett fracture is a simple two-part break. A Rolando fracture, on the other hand, is comminuted. It's shattered into 3 or more pieces. Just think, Bennett is basic, Rolando is ruined.
Let's talk about Gamekeeper's thumb. So this is an injury to the ulnar collateral ligament, or UCL. The big thing you have to look for is something called the Stener lesion. That's when the torn ligament flips out of place and gets trapped, which means it can't heal on its own. And here's the most critical management step. Your next move is to order an MRI. Do not, and I mean do not, perform stress views on the joint because you could actually cause a Stener lesion yourself.
Next up, we've got the Hutchinson's fracture, also known as a chauffeur's fracture. This is an intra-articular break of the radial styloid. Now, as soon as you spot this, alarm bells should be going off in your head because you need to think about its very dangerous friends, scapholunate dissociation and perilunate dislocation. These are huge carpal instability problems that you absolutely have to rule out.
All right, we've covered the breaks. Now let's switch gears to the pulls and tears. We're moving on to some common tendon problems and ruptures that you're definitely going to see around the wrist.
We've got a patient with pain on the thumb side of their wrist. Two common culprits, but they have totally different stories. Quervain's Tenosynovitis is a classic overuse injury. They even call it mommy thumb. And it involves the first extensor compartment. A delayed extensor pollicis longus, or EPL rupture, is different. It happens weeks or even months after a distal radius fracture. And the cause? That tendon is rubbing against a sharp bony prominence called Lister's tubercle, which is in the third extensor compartment. So remember, the location and the timing tell you everything.
Let's compare two more overuse syndromes that can get confusing. Intersection syndrome is a classic for rowers. It's an inflammation right where the first and second extensor compartments cross over each other. Drummer's wrist. Well, the name kind of gives it away, right? It affects drummers, and it's a Tenosynovitis specifically of the EPL tendon, which, as we just learned, is in the third extensor compartment. So again, the activity and the compartment are the keys to telling them apart.
Now, this is a really fascinating and predictable pattern of failure. With von Jackson syndrome, which you often see in patients with rheumatoid arthritis, the extensor tendons rupture in a very specific order. It starts on the ulnar side with compartment 5, the pinky extensor, and it just marches radially, or towards the thumb side, across the wrist. It goes from 5 to 4, and then to compartments 3 and 2.
For our final section, let's dive into the tight spaces of the wrist and talk about what happens when nerves get trapped in those tunnels.
This is such a classic anatomy question. What's actually inside the carpal tunnel? Well, there are exactly 10 structures packed in there. You've got 4 tendons from the flexor digitorum profundus, 4 from the flexor digitorum superficialis, the one flexor pollicis longus tendon, and of course the star of the show, the median nerve. 10 travelers in a very small space.
So when you're looking at an ultrasound for carpal tunnel syndrome, these are the classic findings you're searching for. First, the median nerve itself will look swollen, and it'll show increased signal. As that pressure builds up, you'll also see the nerve get flattened, and you'll see the flexor retinaculum, that's the ligament over the top, start to bow upwards. Seeing those signs together is a dead giveaway.
Let's put the two main nerve entrapment syndromes right next to each other to make it super clear. Carpal tunnel syndrome is all about the median nerve getting squeezed, usually from some kind of repetitive trauma. Guyon's canal syndrome, on the other hand, involves the ulnar nerve, and it's classically caused by direct pressure, like from the handlebars of a bike. That's why they call it handlebar palsy. So different nerve, different canal, different cause.
Phew, okay. We have covered a lot of ground. So let's bring it all home with one final, rapid-fire review to really lock in these diagnoses for good.
Ready? Let's do this fast. A fall with dorsal angulation, that's a Colles fracture. A fall with volar angulation, Smith fracture. An intra-articular rim fracture, you're looking at a Barton. If you see a comminuted thumb-base fracture, it's a Rolando, but if it's a simple thumb-base fracture, it's a Bennett. And finally, that radial styloid fracture, that's a Hutchison. This is your cheat sheet right here.
And that's our rapid review. We've broken down all the key differences and the clinical pearls you need to know. So the real question is, now that you've seen all the patterns, which one of these injuries are you going to be able to spot first?